Colin McWilliams, and this is the PE skills video. My subject, just wanted to clarify the contract that it is okay with you that we perform the physical assessment with you. That's
Yes,
okay?
yep.
Okay, thank you. All right, I'm just going to wash my hands first. And we will begin with the exam. So, first we will have the patient sitting face forward, and we're going to examine general appearance and hygiene. This patient appears to be fine with both of those respects. And as written, the vital signs and health history have already been recorded. So we'll proceed with the physical exam first. So first we'll start with the head. So we're going to first inspect, as always, noting anything abnormal. There doesn't appear to be anything. Next we'll palpate and just kind of scan the scalp for lesions or any kind of masses or bumps, and distinguishing those from bony prominences like the mastoid process. Hair is full thickness and appears to be in good hygiene. So we will move on to the temporal artery. We can palpate on either side, and it is palpable bilaterally. We can move down to the structures of the face. We will have the patient look forward, and we'll go through a series of facial movements. This is also part of the neurological exam to test the cranial nerves. So I'll have the patient smile, clench your teeth, open your jaw against resistance. Good. Move your jaw side to side. This is part of the TMJ assessment. Puff your cheeks out. Good. Raise your eyebrows. Wrinkle your brow down. Okay. Open your eyes. Open your mouth and stick out your tongue. Move it side to side. The tongue is midline. Can you put your tongue up? Curl your tongue up. And the ventral surface is vascular. Good. Okay. Next with the face, okay, you can close them up. Next with the face, we'll palpate the sinuses, and we just want the patient to let us know if they're having any pain or tenderness upon palpation. So I'm gently just going to touch underneath the eyebrows and the maxillary sinuses on the front of the face. Do you feel anything tender? Any pain? No. Good. Okay. Next, we'll move on. Since we're focusing on the head and the neck, we'll do neck range of motion and strength. So I'll have you rotate your head left to right and back and forward. Good. And then your ear to each shoulder. Good. And we'll do those motions against resistance, starting with ear against the shoulder. Good. Push your face and rotate. Good. And flexion extension. We won't really test that one too often. That one, we don't want to put the patient into too much resistance in those fields. So good strength, good range of motion. All right. Next, we will inspect the ears. So we want to inspect the external ear, noting the alignment and anything that's abnormal, any kind of discharge, any tenderness or redness or swelling, including palpation of the pinna and the tragus. Are those sensitive? Do those feel painful when I push?
No pain.
Good. All right. And upon inspection, the ear appears to be in good hygiene as well. No discharge, no drainage. So we will do the whisper test to test for auditory acuity. So I'm going to whisper a word, and I want you to repeat it.
Broccoli. Cinnamon.
Good. Okay, those fields are also normal findings. So next we'll inspect the eye. And to do this, I left my pen light at work, so I'm going to use the flashlight on my phone. First, we'll have the patient. We'll just inspect the structures of the eye: the iris, the cornea, the pupil. The pupils appear to be within normal ranges for size. The sclera is white and vascular at the inner and outer canthus. I'm just going to raise your eyelids. Good. And they're vascular with no discharge, no swelling, no drainage. Those are normal findings. So we'll test extraocular motions first. So I'm going to hold up a pair of bandage scissors and have the patient follow them in 6 different cardinal directions. So follow with your eyes, please. Good. No issues with that. The patient has no nystagmus, no strabismus, nothing abnormal with the eye or the function. Next, we'll move on to the nose. Oh, I'm sorry. We'll move back to the eye. So with the eye, we're also going to check for the corneal light reflex. So I'm going to shine a light in your eye and then on the other eye. Is that okay?
Yep.
Good. And what we're looking for is bilateral pupil constriction, even as the light is shown into one eye or the other, which we do have with this patient. So those are normal responses as well. We will also test for confrontation. So I'm going to bring something into our peripheral field of vision, and I want you to tell me when you first see it, okay?
I see it. I see it.
Okay, good. Those are normal findings as well. That one's a little bit subjective, as the assessor should be, the object should enter the patient's peripheral vision as it enters the same of the assessor. So that is also a normal finding. So, all right, we'll move down to the mouth, the nose rather. So the nose upon initial inspection is midline, it's symmetrical. You can see the septum will shine a light up as well. And there is fine hair throughout, no discharge, no drainage. I'm going to have the patient, I'm going to occlude one nostril, and we're going to test for nostril patency. I want you to breathe out through your nose. Okay, those are both patent and clear. There's nothing blocking or obstructing either near nasal passage, so those are normal findings as well. So next we'll move on to the mouth, and I'll use the flashlight again. And the teeth appear to be in good hygiene with no dentures, no missing teeth, the gums are moist and pink, as well as the tongue and the mouth. I'll have you say ah. The uvula is midline and reactive as well. The hard palate is as well. The tonsils are visible but not swollen or enlarged. Normal findings again. So we tested the TMJ, we tested the sinuses, we also palpated the temporal pulses. So we're going to move on to the neck. So first I'm gonna palpate for a carotid pulse, and you'll do this one at a time so as not to occlude blood flow to the patient's head. Good. Strong palpable pulses. We tested neck range of motion and everything else involved with that. So at this point, I'm going to inspect the neck and the trachea, which is midline. No masses or lesions on the skin. We're also testing the skin throughout each assessment. Let's see. And we'll also palpate the cervical lymph nodes, which are small, firm nodules that shouldn't be tended palpation. Good. Okay, I'll have the patient sit the other way. And we're also going to palpate and inspect the neck from the posterior approach, and this is primary for the thyroid gland. So I'm just going to gently take my hands and press probably midway through the trachea. You can feel that the thyroid gland, specifically when the patient swallows. So I'll have the patient swallow, and you can feel the thyroid gland kind of react upward, and that's a normal finding. We don't want it to be enlarged on one side or the other or tender to the touch. So none of those things are going on with this patient, so those are also normal findings. So while we have the patient in this position, we'll inspect the posterior thoracic cage. So we want to assess the muscles and the symmetry as well. So bones and muscles appear to be symmetrical, nothing abnormal. Posture is good. We'll palpate the spinous processes. They all are in midline with no tenderness. Does this hurt when I press on your spinous? They're all in good alignment. Patient has good posture. We will also, while we're here, we'll test the lung fields from the posterior approach. So first, I'm going to have my hands just below the subscapular, and we'll have the patient take 2 deep breaths, and I have my hands almost like a wing position. So the patient's going to take 2 deep breaths in and out. Good. And we're looking for symmetrical expansion, so the hands should move in conjunction with each other when the patient takes a deep breath. That's what we're finding, normal findings. So, no, you're okay. That's fine. Thank you. So next we're going to auscultate the breath sounds. And we'll start at the apices. So I'll just ask the patient to take nice deep breaths. Good. Okay. So what we did was we tested the breath sounds, the fields of each lung, There are 5 along the mid-clavicular line, and then the lateral lobes will also check down towards the bases. So this assessment revealed no adventitious breath sounds. Lung sounds are clear bilaterally upon auscultation. Bronchiovesicular sounds in the apices of the lungs, and vesicular sounds throughout the bottom. No crackles, as we mentioned, no wheezing or rhonchi. While we have the patient here, we'll also test for costovertebral tenderness, which is a test to determine whether or not the patient has any inflammation or any kind of pathology with the kidneys. So if it's okay with you, I'm going to gently percuss just below the scapula on the right and left side, and I want you to tell me if it's painful. Is that okay?
Yep.
Any pain?
No pain.
Good. Okay, any pain on the left side? So no costovertebral tenderness, so those are normal findings, as we mentioned. So I'll have you sit back forward if you don't mind, please. Okay, so from here we are going to test the extremity. So I'm going to have the patient stick her hands out, and we'll have you turn your hands over. We're going to check the pulses, so we'll check at the brachial pulse. Both are palpable, and we'll also check the radial pulses. Also palpable and strong. We will test range of motion and strength. So I'll have you lift your arms towards you, down to the floor, straight up over your head and down, out to the sides and up. Good, and down. Bring your hands out forward again and turn your wrist over. And I'll have you point your wrist up to you, down to the floor and around, and then back around. I'll have you press up towards you against resistance, and the same thing, pushing down. Good, and then we'll have straight wrists over, and we'll have you push up towards you, down to the floor. Good. We will also check for shoulder shrug. I'll have you do a shoulder shrug, up and down. Good, and against resistance. Good. I would say that patient has no deficits in strength or range of motion throughout any of the upper extremities field. So since we're looking at the hand, I'm going to turn your hand over, and I'll see the other hand as well, please. And I will press at the nail bed to test for capillary refill. And the nail bed returns to its normal color within 1 to 2 seconds. Those are normal findings. So the patient is getting adequate blood flow throughout, all the way down to the distal extremities. So here we'll also test. There are lymph nodes just behind the brachial artery that we will palpate for. They should be small, firm nodules. You can feel them. They're kind of palpable. You do have to palpate a little bit deeply for those. Not tender.
No tender.
Good. Okay, and again, as we mentioned, this skin, we're doing a skin assessment, so I'll use the dorsal side of my hand and test for skin temperature. It is warm. Normal findings again. Okay, so while we're here, I will have the patient, we're going to assess the anterior thoracic cage. So first, we'll just inspect the patient while they breathe. We're noticing any kind of accessory organ breathing, or accessory muscle breathing rather. This patient looks to have a normal respiratory rate, as well as no heaving or accessory muscle breathing. So we're going to palpate the anterior chest, noting for any thrill. There is none. No cardiac heave as well. So now while we're here, we'll also test the lung sounds throughout the anterior approach. So I'll have the patient take deep breaths again, please. Sorry. Okay. And again, just like the posterior approach, there are bronchial sounds throughout over the trachea. As you move towards the apices, bronchiovesicular sounds, and then loud, clear vesicular sounds throughout the bases and the peripheral, the lateral lungs. Next, we'll have the patient lie at about 35 to 45 degrees, so I'll ask you to put your feet up. Scoot down. Good. Okay, so at this point, we're going to assess the patient. Oh, sure. We're going to assess the patient for jugular venous distension. So we can look at the neck. I'll have the patient look left and then right. You should, with jugular venous distension, which could mean a fluid backup, or you see this commonly with patients that have CHF, you can see a very large bounding pulsation on the jugular vein. And it shouldn't be as palpable like a pulse, like the carotid pulse, so you should be able to distinguish that. This patient obviously has none. We already palpated the carotid pulses, so normal finding. So next we will auscultate the cardiac sounds. So first, we're going to start with...
Can we move down?
No, you're good. We're going to start with the aortic valve, which is in the second right intercostal, second right intercostal space. So we want to hear S1 and S2. They're both present. We'll move over to the pulmonic valve in the second left intercostal space. And we'll move down closer to the sternum, but in the fifth intercostal space, we should hear the mitral valve. And then in the fifth intercostal space, over towards the midclavicular line, you should hear the tricuspid valve. And now I'll have the patient lean to the left and forward. And we're staying in the apex of the heart while we're here. We're assessing this position for a murmur, and we'll have the patient take a nice deep exhalation. Exhale. Good. And back flat. We're going to use the bell of the stethoscope over those same fields. And with the bell, we're assessing for extra cardiac sounds. And you can also assess that when you're actually listening with the diaphragm of the stethoscope as well. We didn't hear any S3 or S4. Those are normal findings for the adult. The last thing we'll have to do, I might have missed, was we're going to take the apical, we're going to go back to the apex, the fifth intercostal space, and we're going to check the rhythm and the pulse rate. So I'm just going to look at my phone for the time. And it sounds like sinus rhythm, and it also, the patient's pulse rate is about 60 beats a minute. There's about 1 beat per second. So those are all also very within the normal ranges for sinus rhythm. So while we're here, we'll move on to the abdomen. What we'll do first is we're going to auscultate with the bell over the abdominal aorta. And we're listening for any kind of adventitious sounds. You may hear vascular sounds, but in this case, there aren't any audible. So, excuse me, we're going to proceed with auscultation of bowel sounds throughout the 4 quadrants. So we'll start up in the upper left quadrant. Good, and the patient has positive bowel sounds throughout each of the 4 quadrants. Next, we're going to palpate the abdomen, noting any tenderness or any kind of lumps or masses. Does this hurt at all?
No.
Light palpation, you can't feel anything, no lumps or masses. Again, no heaves, no abdominal heaves. There isn't anything going on cardiac-wise with pulsations or anything abnormal. And we'll also palpate for the organs. The liver should be palpable just under the right midclavicular line of the rib cage, and you can feel a little bit of a mass there. Okay, so now we'll move on to percussion. So for percussion, we'll start with light and then proceed to deep. I'm sorry, percussion is just one test. I'm sorry, I'm thinking about palpation. So what we'll do is we'll go through the 4 fields. We're going to test 3 different locations in each field in a zigzag pattern. And what we're looking for is any kind of difference between each side and each field. So I'm just going to gently tap on your stomach now, okay? Good. So those are resonant percussion sounds, no dullness and no hyperresonance, so those are normal. Dullness may mean that there was fluid in a cavity or that there was something that was obstructing the actual vibration throughout the abdomen. We did not have any of that. So now we'll proceed with deep palpation. And again, we're testing for tenderness and any kind of lumps or masses, of which there are none. Good. Okay. I'll have you lay flat, please. All right. We're going to test the hips, the strength in the hips and the range of motion. So I'll have you lift your leg straight up and down and the other. Good. And I'll have you bend your knee and bend the other. Good. And bring your leg out to me and the other leg. Good. We'll test against resistance. Good. Okay. The hips and the legs have no limitations, no deficits in range of motion or strength. While we're doing range of motion and strength, we might as well proceed with the feet and the lower legs as well. So I'll have you point your toes up to you. Good. And down to me. Good. And there's good strength, no range of motion issues. So again, we're testing the skin with the dorsal surface of my hand. Skin feels warm. There appears to be good blood flow down through the lower extremities. We're going to palpate the 4 different lower extremity pulses. So the first is the popliteal. Right behind the knee, you can feel a nice strong pulse. We're going to use the tibialis anterior and the dorsal pedis. I'm sorry, posterior tibialis pulse and the dorsal pedis, and then the plantar arch. And the patient has good pulses throughout both bilateral and lower extremities. Here we'll also test the neurological function, so I'm just going to remove your sandal if you don't mind. And I'm going to ask you to bring your heel down through your shin in a straight line. Good, and the other. Good. And again, this is a neurological test, so we're testing for any kind of abnormal motion, strays away from the midline. This patient had none. Those would indicate that there was a neurological issue. So obviously we don't see that as well. So while we're down here, we'll also test for capillary refill. Good. Again, 1 to 2 seconds. This is a normal finding. There isn't any issue with blood flow down through the lower extremities. So, okay, so next we're going to have the patient sit back up. We're going to continue with some of the neurological exams. So in this position, we'll also do the knee bend. So while the patient's sitting, I'll have you bring your knee up to you. This is the shallow knee bend test. Again, any pain or any tenderness with that. The patient has good range of motion, good strength. So, okay, so now we're going to test, we're going to move on with the neurological exam. So I'm going to use some different tools here. The first we're going to do is the distinction between light and sharp and dull pain. So I'm going to use the hand piece of the scissors as dull, and then the dull end, obviously the scissor portion, just the dull side of these bandage scissors for a sharp pain. So I'm going to have the patient close their eyes, and on the hands, we're going to test. I want you to tell me if you feel sharp or dull.
Sharp. Dull. Dull. Sharp.
And the lower extremities?
Sharp. Dull. Dull. Sharp.
Good. Okay, normal neurological findings. Next, we're going to test stereognosis. So I'm going to have the patient keep her eyes closed. I'm going to place an object in her hand. I want her to try to identify it through feeling.
A key on a keychain.
Good. Okay. And next, we'll also, while we have the patient here, we'll test for light touch sensation. So I just want you to say yes when you feel me touch you with this paper towel, okay?
Yes. 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 Yes.
Good. Patient was able to identify and discriminate between pain and touch sensation. So next we'll test positional sense. So this is part of like a proprioception test. So with your eyes closed, I'm going to test. I'm going to move your finger and your thumb up or down. I want you to tell me which direction I'm moving it. Okay.
Down. Up. Down. Up.
Good. Okay, positional sense is intact. We can just do one arm with that, I think.
Okay.
So next we're going to do, we're going to continue with the neurological exam. So I'm going to have the patient stand. And then from this part where I'm going to have the patient, first we'll do the Romberg test. So this is a test again for vestibular function and balance and proprioception. So I'm going to have the patient stand with her eyes closed in one position statically. And there should be no aberrant movements or swaying from the midline. 20 seconds is the usual test. And it can indicate that there could be, like I said, something wrong with muscle imbalance, something wrong with proprioception in the brain, neurological function, or something wrong with a vestibular problem in the inner ear, which there is none. The patient is standing nice and straight and still. So next I'll have the patient, I'm just going to point the camera down a little bit so we can see the feet. Okay, so I'm going to have the patient walk just in a straight line to me. And on the way back, I'll have you turn, and you're going to walk heel to toe. And then this way, I want you to walk on your heels to me. And on the way back, I'd like you to walk on your toes. Good. Patient was able to complete this. This is also part of the neurological exam. So, oh, right. The last part of this, I'll have the patient sit back down. And so here is when we would test the shallow knee bend. We already did that. I'm just going to do a test for the reflex, the D10 reflexes of the knee. So I don't have a reflex hammer, but I will use the blade of the scissors, and we'll just test the D10 reflexes here. So I want you to relax.
The blade of the scissors?
The handle, I'm sorry. Where I just want you to use, to let your leg relax. Let me carry the weight. Good. Good. The patient has positive deep tendon reflexes bilaterally. And I think that concludes the whole assessment. I want to thank you very much for your help. And that concludes the skills assessment video. Thank you.